consulting process. They are going to speak about their experience and their perspective on incorporating simulation into Lean and in the Six Sigma environment, and using that to improve processes, and then also talk about a case study where they did just that and the great results they got. These are great guys, and we're really excited to have them share some of their insights with you today. The context for this project, I think, is going to be really interesting for you all to hear, and how they incorporate it into their simulation, or their simulation into their work. Oftentimes we see people doing simulation as independent, standalone projects, and they were really able to bring it in as part of a bigger package, which is really what we want to promote, because simulation can be even more powerful when it's combined with the other tools of traditional process improvement as well as management consulting. With that, I'll go ahead and introduce John and Sean, and if we can just move to the next slide. They both work for ECG Management Consultants, which is a very well-respected management consulting firm that focuses in healthcare only. And so they have a lot of great expertise to bring to this. They've spent their careers in healthcare and really have some unique insights for us today. Just a reminder, in terms of housekeeping, you are all on mute, but if you have questions or you would like to share some comments or ask for some additional clarification, please do use the chat function in the bottom right of your GoToMeeting menu, and you'll be able to enter those questions or share your thoughts. We really do encourage you to do that. We'll have those questions and then some time for discussion at the end of the presentation, and we'll be able to share that with Sean. And so please do that. In addition, you will find a recording of this session available on simulatehealthcare.com. Please go there if you would like to see the webinar again, if you would like to share it with colleagues or friends. And we will also post all of the questions if we don't have time on our LinkedIn group, so that you can further discussion and share some thoughts there as well. So we look forward to hearing from you, and now I'm going to turn it over to ECG.
Thank you, Brittany. Yeah, as Brittany mentioned, John, Bud, and myself, my name is Sean Hobson. We work at ECG Management Consultants. We have been around for over 40 years. We work in the healthcare space, and we work just with the providers of healthcare services. So we work with hospitals, health systems, physician groups, and we do a variety of different types of engagements with those groups. And what we'd like to do today is chat with you about the U.S. healthcare industry for a few minutes, and then just really dive into two case studies. One, these are both from the same organization, and we've been asked by the client to just blind their names, so we have gone ahead and done that. But we're going to talk about a large primary care group that we worked with and worked on some Lean Six Sigma components with that. And then we're also going to talk about an orthopedic surgery case that we actually used simulates to help us model a few future state opportunities with that group, and then we'll conclude with a few key takeaways. So with that, what I'd like to do is just dive into the introduction and the industry overview. And I think a lot of people on the webinar, as everyone knows, the provision of healthcare services in the U.S. We're going through a time of momentous change. We've got reimbursement changes, expectations from customers, outcomes, technology. All of these items are converging to reshape how we think about the market of healthcare services and the market for healthcare services. So what we're going to do is just chat a little bit about the U.S. healthcare industry, and really when we look at the healthcare industry, I think the slide that we have here, we talk about evolving economics, and in other industries, many organizations have really dealt with this for years. And in healthcare, the fundamental economic equation underpinning payments is changing. Initially, for many years, the U.S. industry, the U.S. healthcare industry, was really focused more on a cost plus profit margin equaling the price for that service. And again, as most people know, in the industry, that's changing to where price is more fixed, or now healthcare providers have to think more about the cost of providing those services. And so now we have more of a price minus cost equals the margin or the lack thereof. So really, this is, this is a fundamental shift in how we have to think about how we survive and how we thrive in this industry. And so, there's a lot more thoughts around and requirements for continuous process improvement around managing costs to really help organizations survive. And as soon as, and again, this is, there's probably a lot of folks on the call who've seen this, but in September 2012, the Institute of Medicine published its findings on waste in the healthcare system. And so as we think about the cost plus methodology moving to a price minus cost methodology, out of nowhere, almost overnight, this graphic shows $500, $600, $700 billion, billion with the B, of cost opportunities or wastes in the current healthcare system. And it's everything from fraud to unnecessary services to excessive administrative cost to prices being too high, missed prevention opportunities, and inefficiently delivered services. All of those areas are ripe for Lean and Six Sigma, and really trying to understand and moving through a process to remove some of the waste that's in the system. And again, if we think back to the price minus cost equals margin, there's a lot of margin opportunity here in this one slide. So what I'm going to do right now is turn it over to John, who's going to talk to us for a few minutes about what some of the learnings are from other industries and how we can start to think about Lean and Six Sigma.
Absolutely. So one of the things you'll notice on slide 7 that you see is kind of a really broad definition of what's focused on in Lean and Six Sigma. One of the really interesting things that comes out of the first slide with the waste in the system is, while there is waste associated with unnecessary misprevention opportunities and actual patient care delivered, the major opportunities to really drive costs down across the system are related mostly to inefficiencies related to process and delivery. So you'll see on that slide, you'll see there's unnecessary services, excessive administrative costs, and really that inefficiently delivered services are $130 billion in the system, which is a real opportunity to apply some of these performance improvement methodologies such as Lean and Six Sigma, and really an opportunity to kind of dive a little deeper into using Simulate to really take a little bit more waste out by not having to physically trial every single different iteration of your future state value stream. So if we go on to the slide, I want to give kind of a quick overview of Lean production systems and Six Sigma, just to kind of give a little background as to where we dove in. But Lean production as a whole is a really interesting methodology, and it's really attractive to healthcare because it was essentially born out of cost constraints and limitations. And what I mean by that is, in post-World War II Japan, they were really kind of facing a weak demand market for internal products and some real resource constraints that made it difficult to really arrive at large economies of scale that you could traditionally get from building the biggest machines to churn out the most volume. So they really looked to drive down cost per unit in different ways. And what came out of that was actually the Toyota production system, which was a precursor and ultimately involved into Lean production. But what that is essentially is focusing on really customer value in the end, and looking at the process as a whole and trying to find and eliminate anything that doesn't generate value to the ultimate customer and the end user of the product. So in healthcare, this is a particularly interesting opportunity because, as we mentioned earlier, there are opportunities to eliminate a lot of unnecessary steps without really touching patient care, which ultimately allow providers to really drive down the cost per user. But as far as Lean goes, there's really two main things I want to focus on, and one is just in time, and the other is waste reduction. So just-in-time is more of an inventory control mechanism. But the way I like to think of it in the service industry is being able to provide the service at the time it's needed without having a lot of wait and waste. So if you're at the doctor's office, having the doctor walk into a room where the patient is ready to be seen versus having the patient undress and get ready while the doctor's there kind of eliminates some of that unnecessary inventory. And the other component I really wanted to just touch on was waste reduction as a whole. So in Lean, there are actually 8 different wastes. They're called mudas in Japanese, but there's defects, overproduction, waiting, non-utilized talent, and a few others. But really, these are opportunities across the system to really identify areas to really drive down costs and eliminate unnecessary staff time and some of those unnecessary studies and unnecessary services that IOM report highlights. So there's kind of a natural extension out of Lean, which is Lean Six Sigma. And what Lean Six Sigma does is takes the tools of Six Sigma, which is a largely statistically driven methodology that focuses on reducing defects in the overall products to 3.4 out of essentially 1 million products, or 6 standard deviations away from the mean or median. But the overall goal here would be to really take the overall philosophy of continuous improvement and elimination of these mudas and applying Six Sigma as a way to get there. So using really targeted approaches and very much driven by benchmark analysis to get to the end stage you're trying to get to. So what you'll see on the next slide is essentially this Lean Six Sigma philosophy. I'm not going to dive necessarily into each of these, but we can talk a little bit more about them as they apply to the case. But the main thing to think through is the process. So you define the problem, you measure the current state of it, then you go through and analyze it, look for opportunities to reduce it, then you actually improve it. And I think this stage, in addition to the measure and analyze stage, is a real opportunity to use Simulate, because it allows you to really trial a lot of different iterations of different configurations of these performance opportunities without actually having to waste and use a lot of staff time to run these trials and really make patients wait. So the next slide is kind of a continuation on that, but you can see a little bit of some of the tools we used in this. And during this case studies, you'll see a lot of these future state VSMs and the actual VSMs. So what Valuestream Mapping in this context really is taking a look at every step along the process and identifying those steps that create value and the ones that really are just kind of extraneous at this point. So along the way, you can see a number of different tools, you know, the ANOVA, the correlation and regression analysis, and looking at the wastes and the whys. But really, we were going to focus more of these towards how we actually applied them. Slide 12, you're going to just see a handful of examples, and I think across the industry you're seeing trade journals pop up again and again. And I think whether it's, you know, Healthcare Executive, HFMA, or any number of supply chain magazines, you're going to see Lean Six Sigma applications in healthcare getting a lot of press. You know, in addition to the Mayo Clinic, we've read recently some of the work with CHOP and Children's Hospital, Pennsylvania or Philadelphia, using it to drive down some of their SICU costs by really looking at bed demand and utilization. And in addition, we've worked in emergency rooms and other areas where really capacity has to be there immediately, so there's really no opportunity to waste, really using some of these philosophies to create new systems, whether they're fast tracks of care or different ways to really handle and match capacity to demand. So with that, I'm going to dive into a little bit about one of our cases, and I'll give you a little bit of context to kind of surround this, but one of the major drivers that Sean mentioned is this idea of cost plus margin and the shifting move towards being able to accommodate fixed price products. And as part of that, one of the potential models that's come out quite recently in the U.S. healthcare market is the patient-centered medical home. And in this approach, they really use kind of a team-based care model to coordinate care among staff. They use daily huddles every morning, and then basically plan out the day to really deliver as much care or the care necessary to ensure quality for these patients while minimizing cost. And they do that through coordination. So what we were asked to do is actually brought in by a large clinic, in this case a large primary care clinic, to help them really look at how they can really reduce the ancillary costs associated with providing this PCMH-style care. So not only do they have to coordinate their care and bring all their clinical staff together, they wanted to reduce the overhead costs that really kind of fix on that price minus cost equation. So ECG was asked to actually come in and facilitate some of this performance improvement analysis using Lean Six Sigma techniques to really dive in and kind of understand more about how this clinic was operating and areas for opportunities across the board. So we mentioned this earlier, but one of the main drivers and the tools we used throughout this case was we looked at the Valuestream Mapping. And I think when you start to think through Simulate, Sean will get into how we used it later down the road, this is a natural precursor to that, and really understanding the process of how things move and how value is created along the way. So within this, we actually went ahead and looked through and worked with these executives as well as operational staff. And you'll see one of the key considerations here is go to the Gemba. And what that essentially means is that's Lean Six Sigma speak for really going to the place and observing these observations as they occur. So rather than just getting together and talking about it, taking a look at how the clinic flows, talking to the people who are working, and seeing all the individual movements that they have to do to really understand areas of improvement. Because little turns and a couple steps here and there really total up over the whole patient care spectrum, so really saving some time. So you can see below there's actually the results of this setup, and it's an ugly process as you work through it the first time when you have post-it notes across the board and really outlining different steps. But we looked at two separate work streams. The first was that work stream surrounding the clinical care processes. So getting in there and looking at how you can incorporate the team huddle and how you can really do some of the PCMH clinical pieces. But then that second work stream, which I'll talk a little bit more about as we go, really has to do with the process surrounding that. Not necessarily providing the care, but how do we get patients seen? Who's getting them in the room? How is documentation completed, etc. So we used what we found here to develop recommendations for a future state model. So this is just one of those work streams we looked at, but this is the future state recommendation that we came across for a patient visit. So as you can see, the day starts out with your care team meeting, and then the staff disperses, make sure the rooms are ready to go. But we really focused on areas to work with each step of the way, whether it's documentation or making sure the patient's back and ready in the room for the doctor to be seen. The nurses in this model actually penned orders prior to the physicians and nurse practitioners getting in there based on frequency of occurrence and ordering, so that when the physician comes in, all they have to do is review the standard orders and the stock order sets for each thing and determine whether they're appropriate, and then or just approve them rather than have to go through and manually answer them each. Really allowing the physicians and the NP to perform at the top of their license. But the overall goal was really to look at the way we do things and really make sure that everyone is doing things to the level that they're able to do. One of the motives we talked about earlier was the idea of underutilized talent. And with that, you want to make sure that your most expensive resources, your doctors, your nurses, and your really all the way down the line are working to the maximum level of their ability, rather than wasting time documenting and manually keying orders. You have doctors seeing patients, nurse practitioners seeing patients, nurses taking care of and following through on that, and really freeing up the other staff to take on a lot of the administrative burdens associated with this. On the next slide, you're going to see this large primary care center and what we really figured out of this. So we talked a little bit about this, but optimizing patient flow, whether it's making sure that they're practicing at the top of their license, or making sure that all the administrative and ancillary stuff is freed up so that these people can actually perform their clinical care. But one of the major things that we really have to think through when you launch to any of these projects is making sure that you're able to not only develop, but you can track the measures of success and have targeted objectives on these. So we had set group goals and we're able to meet on a daily basis and really check how did we do yesterday, what can we do to do better, and how are we performing against our baseline. But one of the major things is, when planning these models, it's important to not only have the right expectations, but also to be very realistic about what you're trying to get to. I know you hear Lean Six Sigma and it immediately implies that it's a solution that you can just kind of overlay any problem and fix it, but it really is an investment in continuous improvement along the way. So I'm actually going to hand it over to Sean, and Sean is going to take a very similar case with the same client, but really show how we were able to enhance that using Simulate and really kind of delve one step deeper.
Thanks, John. I think as John alluded to earlier in the webinar, when he talked about just-in-time management and elimination of waste, this next case that we're going to discuss really focuses on that. And so I'll dive in first, and we'll talk a little bit about the situation at the orthopedics clinic and obviously what some of their challenges were and what they were what kind of assistance they required. And so on the following slide, it just provides an overview of what some of the objectives were and some of the key statistics were that we were presented with when we walked into the group, into the clinic. And really a lot of this came out of, yes, the orthopedics group had a facility that they were using, but they felt that they were challenged from a capacity perspective, and they had long wait times. They had a large backlog of patients trying to be seen, and they were wrestling with what's the best way to configure the rooms and configure the process for seeing patients and moving patients through the clinic, so that we could reduce bottlenecks in the distribution of clinics and clinic volume across different sessions, and basically how can we do a better job and be more attentive and accessible to patients. And so on the one hand, those were some of the objectives or some of the challenges, and then and then we sat down and really got into some of the numbers. There were 16 providers, so this was both physicians and physician assistants. There were 9 exam rooms with 2 swing rooms, so they could be procedure rooms or actual exam rooms. They had a cast bracing, a splint room. They had over 14,000 visits, and across those 16 providers and those 9 exam rooms. They also had 4 nurses assisting them. They had 1 medical assistant. They had 2 registration clerks, and even with all of that, it sounds like it's a lot of capacity. They still had about a 10% unfilled appointment. They were running at about 10% of unfilled appointments. And another thing to note is that they were open 5 days a week, and they had those 9 rooms were open. There was capacity in each one of those rooms to take on those 14,000 visits. And so we sat down with the client and really started thinking about and scoping out a plan to figure out, was there a more effective way of developing a workflow or identifying a process that would allow the project objectives to be achieved. So would we be able to improve access to available appointments, reduce wait times, reduce the bottlenecks? And really, when we started thinking about it, well, the first thing we had to do is figure out where are the bottlenecks. The organization thought the bottlenecks were in the exam rooms or with the nurses, and until we figured out what those bottlenecks were, we really couldn't go after developing a way to improve the capacity utilization. And, in any the goal of any system is eventually to reduce bottlenecks and increase capacity. So until we figure out where the bottlenecks are and can really understand how to reduce or eliminate those bottlenecks, it's impossible to move forward. So we sat down and really tried to start mapping out what we wanted to do, and we realized early on that we needed the ability to rapidly simulate the operations within the clinic and try to understand what's going on in the clinic, and as in identifying the work queues, how are patients, how are nurses, how are rooms being used, and what does the queuing theory look like for each one of those areas. We need to be able to monitor resource utilization to really understand where those bottlenecks are. And one of the things that we did notice was that across those 14,000 visits, some of the visits were shorter, 15, 20 minutes, some were longer, a few hours, and all of that rolled together said, although we could go in and do some time study analysis and really get down and dirty with the clinic, it made more sense to roll that up to and use some sort of an application, i.e. Simulate, which was the application that really popped into our head as far as the right one to use, to really figure out, okay, across the operating rooms, across the clinic operations, the space planning, even disaster planning, how could we optimize the overall platform? And when we think about the platform, it's not just the rooms, but it's also the resources that use those rooms, so that we can get 14,000, 15,000 visits through the clinic in a year. And so we started to really dive into the into Simulate, and again, in looking at how to build a reality that's in the clinic in Simulate, we really needed to look at a lot of different components. And really, there were over 500 variables that we realized very early on that were needed. We needed to understand the operating hours. We needed to understand provider schedules, support staff and their schedules. We needed to understand not just the exam room, but what types of procedures or what types of events could occur within those exam rooms. And then we spent a lot of time really detailing out the processes when we have check-in, check-out, rooming, what happens when an individual needs a cast or an image study performed. How does that patient flow through the system? And and I'll get into some of the results later, but you can see once we modeled the clinic operations in Simulate, we were able to rapidly identify a series of different future states, still using the same capacity, but using the capacity more effectively. And we were actually able to eventually. We'll get into this. We've got a schedule that shows some of the results, but based on our modeling and based on being able to run simulations across a full year. Thousands of simulations in 5 minutes, 10 minutes, really gave us the opportunity to change a variety of variables and see how the system reacted without having to tell a physician or tell a provider or tell a nurse you've got to do something differently. We could actually test different realities using the system. And so right at the end of the day, we saw a 19% increase in visits, and across 14,000 visits, that becomes a fairly meaningful amount of visits. While at the same time, we were able to decrease wait time by over 40% and increase physician utilization, actually decrease physician utilization by 17%, just by changing some of the workflows and showing the results of those workflows. And so going back to the bottlenecks, what did we find? Well, we found that the providers were the bottleneck, and that that was a pretty interesting finding, because really when we sit down with most organizations, organizations do everything they can to make sure that the providers are as effective and efficient as possible, and and really we were able to dive into the initial workflow and change the workflow to show that there was a way to make providers or to develop providers a more effective and efficient way of working, just by reconfiguring a few of the steps in the process. And really that's the second major finding, was that the workflows created inefficiencies in the deployment of providers. There were, and I think John alluded to this earlier, so we had, I think when John talked about just in time and, are the providers in the room, and when the provider's in the room, is the patient ready to go and ready to be examined? If so, then there's not a lot of waste in the system. If not, there's a lot of waste in the system. Or, the way to think about this is there unnecessary downtime in the provider's schedule because of some inefficiencies in the workflows or in the process, and when we found that over and over, and so that by modeling that, we could show how inefficient the current process was, and then by making a few minor changes, we could show that there was a obviously a fairly sizable improvement in opportunities. So really, so what do we end up recommending? Well, if we redistribute the clinic sessions across the days, we can actually reduce the wait time for patients. So we found that, Monday, Tuesday, there were more requirements for visits than a Thursday, Friday. And so is there a way to redistribute some of those, both from a provider perspective as well as a patient perspective? Is there a way to move some of those visits around to do a better job of leveling out the capacity utilization inherent in the system? And then and the second piece was how can we modify the workflows, and we can get into that in a little bit, by the providers, and that actually increased the clinic capacity. So there were a few things that were inefficiencies in the system that just by modifying the workflow slightly yielded a fairly tremendous result in improved visit performance and decreased wait time. And so, just going back to simulate for a minute, this is one of the views that we developed. And while I realize there are probably more attractive views out there, for us, this process flow or this flow within Simulate really helped us understand what was going on in the clinic. And so we had resources, we had cues, we had processes, and so this allowed us to really watch providers go into and out of rooms, patients go into and out of rooms, nurses and other providers setting up rooms, and really helped us identify where some of these bottlenecks were, and really figure out as we changed some of the processes what the results would be. And again, we had over 500 variables modeled within Simulate, and so so we had a group of providers that would come in, and we basically saw how providers were using rooms and how patients were moved through rooms. So that really helped just the wait time, different distribution, and different components, and so we could really do an individual room and really happening at how we had down at the screen, we have queuing for registration. The queuing time, so most of the queuing time was fairly low. There was a few that would have long registration times, so we could actually look into that. And in the exam room, we had distribution for exam rooms, and then room capture and room room discharge, and so again, it really helped us understand at a very granular level what was going on in the organization. We were able to reconcile what we're seeing with what the organization was seeing in real life. So there was a good symmetry, and the computer-based world and the actual world were very, very consistent, very similar. And so what we have on the next slide is really what we looked at and the different scenarios we were able to model using Simulate. And so we started with the status quo, and what we have is we're actually able to show that there were about 1,300 patients registered during this time period, and what we did is we did 6-week increments because that was the schedule for the providers. The providers would go through a 6-week schedule, and what we were able to do with this was just, and again, this was output from Simulate. So we started out with the status quo, and then we looked at, okay, what happens if we standardize provider start and end time? So that is the scenario 1, and how does what happens when we do that? And we saw that there was an increase in the number of patients being registered. So we actually got more patients through, and then scenario 2, okay, what happens if we just extend the clinic hours? So all we're doing is we're just adding hours. We're not improving the process or the workflows at all. And again, there's more clinic hours means there's more patients registered, the opportunity for more patients registered. Then we said, well, maybe there's probably some better ways to work, or some change, additional ways to work. And so we said, well, what happens if we schedule providers for 3 3-hour sessions, where before we were scheduling them for 2 4-hour sessions, and so yeah, there is a little bit more, more capacity being injected into the system, but when you take out lunch breaks, it works out to be roughly the same. And so that was one piece. And again, we did see an increase from the status quo as far as patients registered. Then we also really asked the question, okay, what happens if we can change our X-ray process? And right now, the X-ray process was actually occurring during the visit. So we would have people come into an exam room. We'd have a provider come into the exam room, talk to the patient, and say, "Oh, you need an X-ray." And we knew that 90% of the people coming into the, 60% of the people walking into the clinic needed an X-ray, and we had an understanding of what what types of patients needed those X-rays. So we said, well, is there a way to change the process so that people get an X-ray before they come into the clinic, so that we're not putting someone in a room, then taking them out of the room, putting a provider in the room, taking the provider out of the room, and we're actually simplifying the overall workflow process. And so what we did is we said, okay, well, if we were to change the X-ray process, what would happen? And we'll walk through some of these results. But we also have, once we were able to implement this new X-ray process, we found that, and we'll just jump down here for a second. With the new X-ray process, we actually found that the overall time spent in the clinic for a patient was cut by 40%, which is a fairly sizable number. Initially, we had about the visit time was about 100 minutes, and now it was down to less than an hour. So that was a fairly sizable reduction. And so we realized at that point in time we were onto something just from the time spent in the clinic for the patient. At the same time, we also went through and realized that if we implemented this new X-ray process, we could actually increase the capacity within the rooms by 15 or 20%. And so, right, we found that the usage rates for the rooms dropped noticeably during that when we implemented this new X-ray process. And then the other piece that's pretty interesting to understand or identify is when we look at the overall physician statistics, the physician's utilization was running at a little over 100% at the status quo, and we were able to reduce that down to 90% by changing the process so that we had this new X-ray process. Right, so therefore, we've just effectively eliminated or reduced the stress on the bottleneck in the process, which we found to be the physicians. And so once we had that scenario, the new X-ray process, we realized that we could, in fact, increase the overall volume flowing through the system at that point in time because we had additional physician capacity and we had additional room capacity. Although the physicians were the bottleneck, we found that we could actually, in scenario 5 and scenario 6, we could actually increase the volume by 11 or up to 20% by opening up the capacity by implementing this new X-ray process. So again, using Simulate to really understand and test what could go on in the clinic allowed us to come up with a different, modified workflow, excuse me, to really help the clinic change their overall methodology for running patients and moving patients through their system. And so, right, and so, so we were able to create the table on the last slide using Simulate's analytics capability, and we were able to capture both the current and future state. We were able to customize Simulate to the situation, so we were able to effectively change on the fly as we changed the workflow. And some of the nice things as well is we were able to really manage different scenarios and track what was going on then really measure the performance for all the objects, and Simulate helped us identify where the bottlenecks were rather quickly, and we were able to drill into where those bottlenecks are and really change how the bottleneck was affected or how the bottleneck capacity was used. So overall, I think that Simulate definitely helped out during this project, and again, a lot of it was the ability to rapidly generate results in a manner that was easily digestible to both ECG as well as the client, and really provided us with an opportunity to explain what we believed to be the improvement, what would be the results of the improved or the changed process in a rather analytic fashion. So that it was very helpful from that perspective. And so I think we just want to wrap up with the last slide here being, okay, so we've talked about the industry, and we've talked about a couple of case studies, and obviously if you think back to the industry, there's a lot of opportunity to reduce waste within healthcare, and given the changing economic dynamic, we are at the point in time where we need to change how we think about waste in the system and do everything we can to eliminate waste, and realizing that there's a lot of different ways to do that, and people are focused on that. And I think that, or we think of that, the ability to use tools like Simulate to help model, the value statement, the future state, really helps organizations figure out what they can do with the available capacity they have before going out and investing in a large new scale project. Because one of the things we were able to do with the orthopedics group was actually show them that they had some time to really work with their current capacity, their current building shell. They didn't have to go out and buy or build a new shell to expand their capacity. They had room to grow within their current capacity constraints. And so, our ability to marry Simulate with our traditional performance improvement strategies was critical. And I think that there's a lot of other opportunities. Right, we have a lot around the Gemba and really trying to get to the main focus or the main thrust of the issue, or the main issue, and solving that main issue is critical. And then I think obviously once we've solved that first bottleneck or the first issue, we need to focus on continually improving to make sure that the waste or the inefficiencies in the system continue to be driven out, so that we can focus on reducing waste across the entire care continuum. So with that, what I'd like to do is just turn the presentation back over to the folks at Simulate to help us walk through any questions you all may have.
Okay, thank you very much to John Budd and Sean Hartzell there from ECG for leading that discussion. It's been great to see some effective examples of using simulation within lean projects. So now we do have time to answer any of your questions. Just a reminder that if you do have a question, please type that into the chat panel on the right-hand side of the screen. If we don't get enough time to answer your questions today, we'll make sure that we post those questions on our Simulate Healthcare group on LinkedIn. And we are keen to carry on this conversation on that platform after the workshop. So we have actually had a few questions. First of all, we were just wondering, how long did it take to build the model?
Right. Okay. So the question is, how long did it take to build the model for the orthopedics group?
Yeah.
Yes. So I think the design and build phase took 60 to 90 days. There was there was a lot of testing that had to go on, given the fact that we had 500 different variables and layered across 16 providers and 4 nurses and 9 different exam rooms. It took about 90 days to build and test, but once we had the model built, it was it was fairly rapid in our ability to model different scenarios. It was important that we got the current state right, and that was functioning correctly. And so, once we had that, it ran pretty rapidly after that. But it probably took 60 to 90 days. And Todd, I don't know if that's consistent with what you're seeing in other clients or in other industries, but that would be an interesting question to expand out to more than just healthcare. Is that a standard time frame?
Yeah, it would be great to hear people's thoughts on that matter. Just to kind of expand on that question, along with the timeline, what were the kind of resource requirements that you had to create the simulation model before you could kind of run it and get results? What resources did you really require towards that?
Well, because this was our first model that we built within Simulate, we had a senior consultant who worked on the project, and he was dedicated half to 3/4 time for those 60 to 90 days to build this. Given the complexity of the model, we did work with Brittany and the Simulate team to help us through a couple of challenges. Some of us have been in prior industries and have built these types of models before using other packages, but each package has its own idiosyncrasies, and so really getting the terminology correct and some of the additional coding. We probably had a gentleman spend 3/4 of his time for 60 to 90 days, and then we did have some assistance from some folks at Simulate, just with some of the idiosyncrasies and some of the tougher pieces to walk through.
That's great, thank you. Another question we've had through, are there any other ways you can see the use of simulation and management science techniques in general applied on a regular basis?
Yeah, I think one of the interesting things that Sean has kind of pointed out is the uniqueness of each of these projects is kind of taking you in different directions from a resource requirement, really having to dive in and understand those 500 variables. But one of the really interesting opportunities in the market right now is looking at how you can prepare a product like Simulate with some of the data mining techniques out there to really look and see, are there ways you can discover and better group processes so that you can really understand the time constraints and time associated with each process without necessarily having to spend hours and hours on end, doing time studies or trying to measure processes. So, a good example of that would be there are people out there when an emergency room is characterized by variability. So really being able to understand, you can't map out every single symptom that could walk through that door, but what you can do is apply some of these analytic tools out there to work with a company like Simulate to really group these people into logical ways according to the process.
Yeah, I think there's another opportunity is when you look at some of the human resources issues that are out there, opportunities that are out there. When you look at nurse staffing and just staffing and scheduling in general, and the ability to put the right resource at the right place at the right time, I think there's opportunities for simulation to help do that and help revise workflows around that.
Okay, thank you. And the final question we have right now is, do you see the role of performance improvement methodologies changing in the healthcare industry?
I mean, if anything, it's only going to grow more and more. I think we've kind of stressed it again and again throughout our presentation that we're moving to a very different price model in the U.S. that really will focus more on, not how much it costs, but essentially a fixed rate. And with that, there are going to come a lot of challenges in terms of having to make difficult choices along the way to really figure out what you can and can't afford as an organization. And I think rather than going after patient care opportunities, it's really important that you first go after the low-hanging fruit of really just non-value add waste. And I think whether it's Six Sigma or Lean Six Sigma, TQM, whatever it is you're looking at, I think performance improvement methodologies are only going to be more and more important as we go forward.
Yes, I think I could certainly, we agree with that here. I mean, it's an industry that's changing so rapidly that I think using any of these methodologies is going to become vitally important.
Yeah, I think just to add to that, I think you're absolutely right. I think that whether or not it's PDCA or DMAIC, it's important to at least start putting those in place and getting people comfortable with thinking about those types of methodologies and how to continually look at what they're doing, and is there a better way to do it that could reduce any seen or unforeseen waste or inefficiency in the system.
Okay, brilliant. So that's all the questions we have right now. Just a reminder that if you do have any further questions following on from this, that you can ask them on our health LinkedIn page. That's Simulate Healthcare on LinkedIn. And any conversations we'd be happy to be involved in there. In terms of these webinars, we run them monthly, and if you do have a topic that you'd like to see covered, then please do email that to our healthcare lead, Claire Cordeau. That's claire.c@simulate.com. And that really concludes our workshop for today. So thanks again for your time. Thank you again to the presenters, and we look forward to welcoming you to workshops in the future. Thank you.